Hello, everyone, and welcome. Thank you for joining the Marfan Foundation and its divisions for our 2026 Global Virtual Conference session, Understanding the Updated LDS Primer for Diagnosis and Management. I'm Stacy Watson, Director of Loeys-Dietz and Marfan. My colleague Helene is behind the scenes helping to ensure that everything runs smoothly during the session. The session is being recorded. Before we begin, I want to make note to use Zoom's Q&A feature to submit questions throughout the presentation. We'll answer as many as possible during some time for Q&A at the end. And the chat is available for discussion and comments, but questions posted there will likely be missed. So please use that Q&A tab for all questions. It's my pleasure to introduce our speakers. Gretchen MacCarrick is an assistant professor and board certified genetic counselor in the Department of Genetic Medicine at Johns Hopkins. She is co-founder of the Loeys-Dietz Syndrome Foundation and a member of the professional advisory board for the Marfan Foundation. Gretchen is also the lead author on the updated primer. We're also joined by Dr. Julie Richet, a medical geneticist at CHIO and associate professor of pediatrics at the University of Ottawa. She has expertise in heritable connective tissue disorders, thoracic aortic disease, and cardiogenetics. Welcome. We're so happy that you joined us. Please begin when you are ready.
Thanks, everyone. We are very, very pleased to be here. I'm so happy Julie is joining us. And we are talking about the updated care management primer that just came out. It was actually officially just published last week. And I'm sure in the chat, they'll put the link that you can check it out. Let's see, making sure it can go forward. Okay. And so this was an effort by many, many people. I think we have 7 different countries represented, more than 40 authors of at least 7 or 8 different subspecialties. So we're really excited and yeah, really proud, I think, of how all of the professionals came together to really review the literature and give you the best care management advice. So the goals of this talk is to really kind of understand what has changed since the 2014 primer. That was the last time these management recommendations came out. You know, it is not 100% complete. There's still lots of areas that we need to learn about. And so we admit that. And so, you know, care recommendations are continuing to evolve. Kind of thinking through the major organ systems we think about in Loeys-Dietz syndrome and understanding our current recommendations about surveillance, medications, exercise. And really, one of our goals for this primer was that we want every patient, regardless of where they live, regardless of access to what center of excellence you have, to have the same information, to feel empowered, to really be shared decision makers in your care and be able to take this, give this to your physicians, but also you use it as a personal reference to advocate for yourself. So just a little bit of a historical journey, if you'll give me a little leeway. You know, Loeys-Dietz syndrome was first described in 2006 by Dr. Loeys and Dr. Dietz. Dr. Loeys was a research fellow at Hopkins at the time and noticed kind of some atypical Marfan cases, and that's kind of how the Loeys-Dietz story evolved. The Loeys-Dietz Syndrome Foundation was first founded in 2007, and the first Loeys-Dietz primer was written in 2014. It was primarily kind of a hub of Hopkins physicians because we had seen quite a bit of patients at that point. In 2015, kind of our vascular orthopedic expertise was really expanded by having the NIH open a natural history study. So that really opened up the door to more of the bone health, the allergy, the immunology study of Loeys-Dietz syndrome. In 2021, we became a division under the Marfan Foundation and are pleased to have such wonderful community now under the Marfan umbrella. So why is now the time to publish an updated primer? Well, we've had significant advances in both genetics, in our genetics discovery, in our understanding of precision medicine, as well as imaging advances. We are beginning to have a better understanding of subtype differences. So I know the next talk we'll be talking about some differences of subtypes. We have more long-term surgical and medical data. So now we have 20 years to look back at our experience. We also have an appreciation for some of the extra aortic manifestations. So this primer really pays more attention to multidisciplinary care and a greater emphasis also on precision medicine. Guidelines are kind of how we take care of everyone as a whole. And the primer really puts emphasis on kind of you or your family member as an individual and what we can learn from you and your family and your genes specifically. So, key concepts that we want you to keep in mind are variable expression. That means that not every person with Loeys-Dietz is going to have the same history. Loeys-Dietz gene is one gene out of 23,000. Your environment, your other genes can play a part in your manifestations. So, every disorder or every manifestation organ system we talk about, not everyone is going to be impacted by that, and not everyone is going to be impacted by the same severity. There's incomplete penetrance. So we do know in some Loeys-Dietz syndrome cases, especially in the milder cases, even if you have a Loeys-Dietz gene change, you may not have aortic dilation at a young age. You might not ever have orthopedic complaints. So some people can have a gene change, but not show, very significant outward manifestations of it. Some subtypes are generally more severe vascularly, so we'll be explaining that this afternoon. And then even the same gene will not have the same outcome. So this is all that there is a lot of variability. And so when you're going through the information we're presenting, you kind of have to go in with a filter about you and your family as compared to the whole. So some important themes just to touch upon. We in the 2026 primer, we think there's more personalized management, again, looking at you or your family as an individual or a group. We have much more genotype informed risk assessment, more nuanced surgical timing. So that 4 centimeter mark is not for everyone. And we describe that. We do know that head to pelvis vascular imaging is essential, but also in the guidelines, we kind of break down where there might be some leeway in the timing and how frequently different subtypes need that imaging. Again, a growing attention to quality of life and that shared decision making between you and your physicians really, really matters. So just as a brief overview, we in this paper talk about 6 types of Loeys-Dietz syndrome. They're all autosomal dominant, meaning that each person with it has a 50-50 shot of having a child with it. There is a 7th degree gene that is somewhat described in the primer. We're not officially calling it Loeys-Dietz 7. It is actually a recessive disorder, so meaning you need 2 gene changes in a gene called IPO8 to have this disorder. So the inheritance pattern is different. It has a very similar overlap in terms of vascular features and some of the orthopedic and features. And so there is the question whether it might eventually evolve into Loeys-Dietz 7. So it is involved in the primer, but hasn't officially been characterized as Loeys-Dietz 7. And of course, there are probably many more genes in the TGF-beta pathway. So there might be Loeys-Dietz 7, 8, 9 eventually as more discoveries are made. So Julie is going to take us through some of the cardiovascular disease.
So good afternoon. Thank you very much for the invitation and for being here. I'm Julie. I'm a medical geneticist, which also means that I'm not a cardiologist. So just keep this in mind. So we wanted to talk about the cardiovascular features in Loeys-Dietz syndrome because everybody hears about the risk of aneurysms, particularly close to the heart, but also elsewhere in what we call large and medium arteries. So if you think of the aorta as kind of the main pipe coming from your heart, there's other arteries or blood vessels that go from that aorta to go and give blood to your organs. So those arteries are also at risk. We also know that there will be some people who will have what we call congenital heart disease. So that means a difference in the way the heart is shaped that people are born with. The main one that we see more often is called a bicuspid aortic valve, which means that the valve that normally sits between the left big chamber of your heart and the aorta, that big pipe, is normally supposed to have 3 leaflets, kind of a peace and love sign. But for some people, it only has 2 leaflets, and that can change the way it opens and the way the valve functions. So for that, people have to be followed for their valve too. We can also see differences in the mitral valve. So that's the valve that sits between the small and big chamber of the heart on the left side. And that valve can do a number of things, including what we call a mitral valve prolapse, where it kind of, just like, sometimes joints go backwards. Well, sometimes the valve go backwards, and that's what we call a mitral valve prolapse. And when it prolapses, sometimes it leaks too. And some people can also have something where the valve is not quite seated the way it should be seated. That's what we call mitral annular disjunction. And that can come with a higher risk of heart rhythm differences. So all of those things are important for your cardiologist to look at. And like Gretchen said, the risk is different depending on the specific gene, but also different even within people in the same family. So in the primer, we explain basically what are the advantage and disadvantage of an echocardiogram, the ultrasound of the heart, and a CT and an MRA. So the CT and the MRA are studies that can be done for your brain, the rest of your aorta, arteries in your abdomen, and your pelvis as well. The CTA is like the donut that people go in. It's a fast test. If we're thinking of a dissection, that's definitely what we want to do. Often surgeons will use it also to plan a surgery. An MRA is the one where you go in the tunnel and it's really loud. The advantage of that test, even though it takes longer, is that there's no radiation. It's a magnetic field. And what we say in general is that the echo should be done every year or so, a little bit more often if the dimensions have changed, if you started a new medication or things like that. And in one specific subtype called TGF-beta3, which we know can be milder, sometimes we can be a little bit looser. And in terms of the brain to pelvis imaging, that's typically, it depends on what we find the first time. But if everything is normal and your aorta is normal and we've never found anything, often it's about every 2 to 3 years. But if we find things, that will be more often. Children and adolescents are a little bit of a different story. So children and adolescent, we typically say, well, at baseline, but there is some provision for some genes that may be a little bit milder to wait, so that particularly for an MRI, so that they're able to stay still by themselves. Because before putting a child to sleep, the risk benefits, that kind of teeter scale, need to be a little bit different, of a higher risk to warrant the benefit of having to put a child to sleep. But those are all things that your cardiologist will discuss with you. So, like we said, how often we do the imaging depends on the gene, on the size of the aorta, how it's been growing, but also sometimes on your family history. If we know that you have some close relatives that were very severe or that dissected, we'll want to be a little bit more careful with you, because just like Gretchen said, the gene for Loeys-Dietz that you have is one gene out of 23,000 pairs of genes. So there's lots of other genes that can modify things, a little bit like your height and your intelligence. That's not one gene, that's a number of things. So in this case, we know that the gene for Loeys-Dietz is what we kind of call a strong driver, like this pushes on the pedal quite hard. But there's other things that may modify things. But if somebody in your family close to you was severely affected, we're a little bit more concerned that there's more of those other genes that kind of push on the pedal. And obviously, if you had a dissection, we'll want to be watching you a little bit closer. Why did we put sex? Because we know that as a group, women tend to be less severely affected than men as a group. It's not true on an individual basis. We've seen women who are severely affected, but we know that when we put enough people together, chances are a little bit more in your favor if you're women than a man. Your cardiologist will also talk to you about medications. Angiotensin receptor blockers are a class of medication. People call them ARBs. That are things that are sartan, irbesartan, losartan. And those we know can help protect the aorta in the long run. At a good dose, that helps how the wall of the aorta kind of maintains itself. Some people also use a class of medication called beta blockers. Those are the LOLs, lebetalol, bisoprolol, those kind of medication. And sometimes both will be used together, both classes, when the aorta is growing fast. But we talk about all that specific management, but it doesn't mean that things that are true in the general population are not important for you. They are very important. You need your cholesterol to be well controlled. You need to please not poison yourself every day by smoking. You need your blood pressure to be well controlled. And blood pressure is a big one. And those two medications we just talked about, they also help to control blood pressure. So it's important to stay generally healthy as well. So we've just talked about those medications. So the angiotensin receptor blockers, they affect the structural integrity of the media, which is the wall of the aorta. They have the advantage that in people with more severe asthma or depression, these medications won't make it worse. But they cannot be used during a pregnancy because they're associated with a higher risk of birth defects. Migraines, on the other hand, for people who have those arrhythmias, as we talked about, where their heart rhythm is a little bit different, they can be helpful. And some of them are also quite helpful for people who have migraines to help get less migraines. For individuals with normal aorta, sometimes your cardiologist will talk to you about medications, but not all the time. And whether it is worth starting a medication that you'll have to take all your life will depend on what specific type of change you have, what your family history is, etc. But this is also one of the places where there's a lot of shared decision making to discuss together. Surgical thresholds. This is something, again, that you discuss with your team. There's way more than a single number that goes into a surgical threshold. There's things like the specific change, your family history, how things are growing, sometimes also the expertise of your center. So these are there to kind of provide a guide. The other thing that will go into this is that sometimes we see something else outside of your aorta, like really, really twisty, windy vessels in your neck. Or sometimes we see that what we call the craniofacial features. So when your doctor, your geneticist examines you, if they say, oh, actually, you have other things, sometimes we know that for some people that can be a marker of severity. So it's really putting all of this together. And these thresholds are for people who are not planning an imminent pregnancy. So if you're planning an imminent pregnancy, there are other talks in this conference about pregnancy, and this is a much longer conversation. So we encourage you to go to those talks. In terms of the mitral valve, we can have the prolapse where it backflows. That can be mild and that can be more severe. If it backflows too much, that can also be a reason sometimes if a valve is not working well to kind of go to surgery a little bit sooner to kind of do both things at the same time. And the mitral annular disjunction is when the valve is not quite seated properly, and that can give a higher risk of heart rhythm disorders. And we can see it with all of the Loeys-Dietz genes, but there's some authors that have suggested it's more with SMAD3. And the arrhythmias, the heart beating different, more with the mitral annular disjunction, but it can be with even without. And you need to have an EKG, not just an echo, which is an ultrasound of the heart. And we've talked about the congenital heart defect. Those congenital heart defects don't appear over time. You have them or you don't. And Gretchen will talk about pairs.
So pairs might not be as familiar to our US friends, but we really wanted to make sure that the primer addressed kind of a worldwide view of Loeys-Dietz syndrome. So pairs is a procedure, personalized external aortic root support, where it's kind of like a wrapping procedure. It's very cool. They do a 3D representation of your aorta with a graft, and they're able to graft it around your aorta. And this is a procedure that's available in Europe currently. So we made sure to look at the data to look at the patient or what was known about this procedure in Marfan and Loeys-Dietz. And kind of the safety and efficacy of it. So we give some advice that it is a well-received surgery. There are still some unknowns about impacting the coronary arteries. Usually the pairs procedure is done at kind of smaller dimensions in general. Even in patients with Marfan syndrome, you're doing it at the low 4 centimeter mark. So we do address kind of the pair surgical thresholds and the surgery in our primer though.
So there's the question of exercise is something that people ask a lot about, and the conversation has changed. So before we used to say, don't do any exercise because it will raise your blood pressure, and raising your blood pressure puts more stress on the aorta that we know is fragile. And then over time, we kind of said, yes, but except that if you never exercise, your blood pressure all the time goes up. And maybe that's not what we want to see either. And we also know that exercise is important for your joint. It's important for your mental health. It's just important in general. But we still want to make sure that you do it safely. And as a start, that means avoiding extreme strain. So we don't want you to lift heavy weight, be so short of breath you can't talk. And this, again, is something that is worth a conversation with your cardiologist. There's more and more research going on, and there's some people who are starting to look at how much your blood pressure increases when you exercise, because it's not actually exactly the same for everyone. But how restrictive will be will depend on your aortic size, whether you dissected, whether there's other arteries, your family history, whether your valves are working well. And also, we'll talk about this in a further slide, but also what outside of your vascular system that people with Loeys-Dietz syndrome are more likely to get. Do you have, for example, do you have issues with your joints, with your eyes, etc.? That would also play into that conversation. So there are cardiology papers that kind of put different sports on a matrix like that. Again, something to discuss with your cardiologist about what you're allowed and not allowed to do and how. It's different a competitive sport than a recreational sport, for example. So all of that requires a lot of individual advice. And we know that in Loeys-Dietz syndrome, there's also a component of what we call joint hypermobility. That means that the joints move more. And joint hypermobility can lead to instability, where it kind of feels like it will pop out, or it does pop out. It can also lead to pain over time. And it is often associated with what we call poor proprioception. Proprioception is knowing where you are in space. If you close your eyes and lift one foot up, do you still stand up or do you lose your balance and things like that? And that's in part because those receptors are in the ligaments. So people will want you to work with a physiotherapist to strengthen your muscles. We know it requires more strength to stabilize a hypermobile joint than a normal range joint. Think of us having a fight on each side of the door, one of us close to the handle and the other one close to the hinge. It's not a fair fight. Now add a foot, it's even less of a fair fight. So you actually do need to be strong, but we need to strengthen you safely. That's why most people will work with a physiotherapist, and sometimes bracing or splinting will be used as well. They will want to evaluate whether your neck is stable before anything, because that obviously can be dangerous if it is not stable. So those are conversations to have. The other thing that we do know that people with Loeys-Dietz syndrome are more likely to have, and which seem to affect quality of life a lot, is things like dysautonomia, POTS, and headaches. So dysautonomia, there's a part of your brain that we call the autonomous nervous system. It sounds like automatic because that's exactly what it does. It controls your breathing, your heart rate, your blood pressure, and that's what makes your blood not all stay in your feet when you stand up and go to your brain, for example. And that's what controls your temperature. And we know that in some people, it doesn't work quite as fine-tuned that it is supposed to. So there are things we can do. Sometimes there are medications that can help with that, but it's important to be aware of this. The classical example is often gardening in the summer, where you're in the hot sun, you don't drink much, and then you go from squatting to standing up. That is not the best idea. So again, there's things we can do to help, but it doesn't mean that it will completely resolve. People with LDS can get both migraines and headaches. We actually don't know exactly how frequent migraines are in LDS, but we know they're a lot more frequent in Marfan syndrome than in the general population. So that will be one of our next steps, is asking you how frequent migraines are in LDS. But it's important to know because migraines are treated slightly differently than headaches. And there's one class of medication in particular that are called triptans that are often used for migraines in the general population. And those can have quite a bit of an effect on blood pressure. So there's other classes of medications that are better in people with LDS. So if you think that you have migraines, talk to your doctors. There are neurologists who specialize in migraines and headaches. And migraines are associated with a lot of fatigue, not only while you're in pain, but often the day after. So in terms of being able to kind of carry on with your life, do your exercise routine, etc., if there's something we can do to help control those migraines, that's something to ask your doctor about.
We're going to switch back to some other of our vascular management. So Julie gave us a lot of information on the MRAs and CTAs looking at the chest. You know, when we're thinking about neurovascular involvement, we're thinking about those vertebral, carotid, cervical arteries in your head. And I think in Loeys-Dietz syndrome, kind of the neurovascular involvement might be the great equalizer. If we look kind of across populations, we do see both tortuosity, so those windy blood vessels, but we do see neck vessel dissections or aneurysms and head blood vessel problems in kind of the majority of Loeys-Dietz genes. Often it's going to dictate how frequently and by what modality we're going to be looking at those head and neck vessels. In general, for Loeys-Dietz syndrome, surgical thresholds and guidelines are the same as in the general population. So many of the neurosurgical colleges have come out with recommendations about size, growth, location. And in Loeys-Dietz syndrome, kind of that intervention mimics those general populations. Oftentimes, if we find something, we are going to repeat imaging. Oftentimes, aspirin or antiplatelet therapy is recommended. But at this point, it really is a good idea if you have a cerebrovascular finding to have a neurovascular specialist, either a neurologist or a specific neurovascular person kind of involved in your care, dictating timing and type of imaging. In terms of spine and orthopedics, we've a bit are kind of defined kind of the spectrum of issues that can go on. We know that there can be a lot of spinal abnormalities, including curvature of the spine, scoliosis. Spondylolisthesis is pretty common. It's where there is some slippage back and forth of the spine. Often it can be in the cervical spine or the lumbar spine area. And if that slippage gets to a severe enough amount, it might need stabilization because your spinal cord is kind of in the middle of those spines. And so if it's slipping too much, it can cause some neurological damage. So we're very certain to not only do the cervical spine imaging at diagnosis, but make sure that we're following the spine and doing any imaging if there is any back pain. We know, as Julie was talking about, there can be joint laxity and pain and a lot of mobility and kind of morbidity associated with that, just affecting day-to-day life and pain thresholds. We see foot deformities, either very inwardly rotated feet or sometimes club foot in Loeys-Dietz syndrome, as well as we can see earlier osteoarthritis. We'll talk about in the different subtypes. That's kind of how Loeys-Dietz 3 first came to attention, and also some bone fragility. And so any type of orthopedic problem, you want to talk to your geneticist, your primary care physician, and they might involve either an endocrinologist for bone fragility issues or an orthopedic doctor. So again, the bone fragility, the bone health is kind of an emerging part that we're learning about, but we do see an increased risk for osteopenia or osteoporosis. In young kids, we can see this, especially in kids who have very severe inflammatory bowel disease or malnutrition or the GI disease that is impacting kind of nutrition. And then we can see it as individuals get older as well. And so this is a place where we want to ensure adequate calcium and vitamin D. You know, if someone is starting to have a lot of unexplained fractures or bone pain, compression fractures of the spine, we would consider a DEXA scan screening, which is a way to look at kind of how dense your bones are. We do know that in individuals who have to be treated for osteopenia or osteoporosis, that bisphosphonates, which is the typical therapy, is safe for individuals to use. And just making sure that, especially in our young kids, there are additional contributors to poor bone health, like the nutrition disease. You know, some of our kids have some chronic inflammation and have to be on steroids. So really looking at the whole picture, both in a young, severely affected child, but then through the aging process. You know, over time, we've come to appreciate more and more about the allergy, immune, and GI features. We'll talk a lot about this in our next talk too, about the different subtypes. A lot of this has been really studied in types 1 and 2, but we do see across all types increased risk of asthma and food allergies. We see constipation quite frequently in a variety of connective tissue disorders, probably having to do with how our smooth muscle in our GI system is able to squeeze and move things along. In some types of Loeys-Dietz syndrome, we can see a very specific type of GI disease called eosinophilic GI disease that can happen in your esophagus or in your bowels. And so a lot of people think of inflammatory bowel disease as Crohn's disease or in your GI tract having bloody stool, diarrhea. But we also are on the lookout in children, most specifically, and adults with food allergies, is that are they avoiding food? Do they feel like food is getting stuck in their throat? Are they losing weight because they're avoiding whole kind of classes of food? Those are kind of some of the things that we think about in Loeys-Dietz syndrome. The presence of inflammatory bowel disease is definitely increased in Loeys-Dietz syndrome. And a lot of this, again, is in types 1 and 2. But it's very important to know some of the treatment strategies if your child is in pediatric GI disease, of what can be used, what shouldn't be used, but really monitoring growth and nutrition, and knowing that endoscopy going down and colonoscopy going up, it should be done in a controlled environment, but it is safe for people with Loeys-Dietz syndrome to undergo. As opposed to vascular EDS, we might have some concerns about GI fragility. We have done scoping on a lot of individuals to look for eosinophilic disease and haven't seen any specific concerns for fragility. So if those interventions are needed, they are safe. We have, thanks to our NIH team, lovely, robust sections on craniofacial, dental, and ENT in the primer. Again, thinking about cleft palate, many individuals can have a soft cleft palate that might not be overtly evident, but is palpated on exam and need to be followed in cleft clinics. We do know that there's increased dental enamel defects, and this can also really impact quality of life and just cosmetic presentation and how you present yourself to the world can be impacted. So we have some recommendations on that. There are some new information about hearing loss in the different subtypes in terms of sensory neural versus conductive, and we have a very low threshold, especially for children as they're presenting to kindergarten and school in those years to make sure that the hearing is really on track. So a very low threshold for getting hearing exams in childhood and then in adulthood as well. And then also an increased appreciation of sleep apnea risk. So many individuals think about sleep apnea in someone who might be very obese or have a lot of kind of visceral fat. But we know that this is increased in connective tissue disorders, perhaps unrelated to size of someone. And not only can it disrupt sleep and make you very tired, but we know that untreated sleep apnea can impact the cardiovascular system in a negative way. So really having a low threshold for getting a sleep study, if there's any snoring, feeling like you wake up and you're not rested, or falling asleep in the afternoons. In terms of ophthalmology, I think Dr. Doyle just gave a talk on this maybe yesterday, and probably went over a lot of this information. We can see myopia in Loeys-Dietz syndrome. And, as a large review, there's not really good data to know about LASIK surgery. I think in the very beginning, we were a little concerned about it in general for connective tissue disorder, but many people have undergone it safely. So we don't really have current recommendations about to avoid or go forward with it. We do see eye muscle disease. So, especially in children at the end of the day or after a long school day, they can get wandering eyes. And we know that there can be some eye muscle differences in kids with Loeys-Dietz syndrome. And so just making sure that if your child is having any ophthalmologic surgery for strabismus or esotropia, that the surgeon is aware that there can be muscles in different places or kind of looking a little different than expected. Retinal detachment risk is associated with Loeys-Dietz syndrome. It's not as high as Marfan syndrome. I think when we look at our population, it's, maybe less than 1%. But this would be something where someone would experience abrupt vision loss, see flashers of lights, feeling like a black curtain is going across their eye. This is an emergency room visit. And so, we do recommend a baseline evaluation. We do recommend counseling about retinal detachment risk, but ophthalmology evaluation is not something that needs to be on your yearly checklist unless there are features that you have. In terms of pulmonary, we do see asthma and reactive airway disease. We sometimes see tracheobronchomalacia, so your breathing tube is just a little bit more floppy or not as strong, going along with the connective tissue features that may need to be taken into account if you're having any type of surgery or kind of intervention with a breathing tube that might make that a little bit more challenging. We do see collapsed lungs and emphysema, so we're really trying to study more about the pulmonary features. But again, we talked about, having a very low threshold for a sleep study. I can't remember when I was flipping over to Julie, but if not, I'll just keep going. Okay, cool. As I said, we're both in the genetics field and not specifically OBGYN, but we are very lucky to have Dr. Russo and a team that she put together to address gynecological health and hormones. And we also realize in connective tissue disorders in general, this is a really big place where research is needed to help our women really thrive and like have a very good quality of life. We do know that heavy or painful menstrual bleeding may occur. Again, not everyone. Pelvic floor dysfunction can contribute to constipation and pelvic symptoms, and this can occur after pregnancies as well. We do ideally want pregnancy planning to be planned very much in advance and with full shared decision making with your OBGYN team. Many individuals are followed by a high-risk MFM or maternal fetal medicine specialist. So if you get that referral, if you're thinking about pregnancy, do not be surprised. And we also just know that sexual health and quality of life matter, and that, these should be conversations that you're having with your healthcare team to make sure that you are having a good quality of life. So in general, just recommending routine gynecological care and screening, reviewing medications before conception. This again is not just the cardiovascular medications that Julie talked about, but pain medications and other things that you're taking in general. The team from the gynecological section put together a very nice table on contraception advice in Loeys-Dietz syndrome. So a great place for you to think about the different types of birth control and have those conversations with your physicians. In terms of pregnancy, many individuals have successful pregnancies. Some of the difficulty that we see is just that sometimes we can't predict who may run into blood vessel problems during a pregnancy. We know that complications are most likely to occur late in the third trimester or even in those postpartum period. So again, that shared decision making about a delivery plan, what you're going to image, how frequently after giving birth, etc. In general, people are taken off of ARBs and put on beta blockers. They get echoes usually every trimester, and they work closely with their OBGYN or maternal fetal medicine team to develop a plan that's right for them. In terms of mental health and living with uncertainty, I'm really proud of Julie and the team that we put together to really try to address some of those issues like dysautonomia and headaches, kind of just beyond the vasculature as well. Realizing that mental health, dysautonomia, headaches, mobility issues, finding PT can be really challenging and ultimately be impacting the day-to-day quality of life. And so we do in our paper make sure that we address that people should be getting the correct psychological support that they need. And this can include both therapeutic outlets, getting out in nature, and also medication outlets as well. And of course, we know that community sport can be highly valuable. And so we're very appreciative to all of you being here today, sharing your stories, and being here for one another, because I think that can be very powerful in the support of one another as well. I will point out with this QR code, thank you, Julie, that we have put out a book, Life with Aortic Disease, Caring for Your Mental Health. And you can access this as a book, as a PDF. The John Ritter Foundation, I think, has some books left, but it's also a great resource if you're looking for online therapeutic outlets or how to talk to your family members, etc. So I highly recommend you check that out. Okay, thanks.
Thank you, Gretchen. And Gretchen did a phenomenal job with that booklet that has like 88 pages. So they call it the booklet, but it's actually a very comprehensive resource. And some people say 88 page, that's a lot. You don't have to read it all. There's sections. So if that sounds too much, just take a look at what you think might be useful to you. The primer has a section, a table that is called medication that require careful considerations of risk and benefits and frequent monitoring. That doesn't mean that these medications can never be used, but that means that there's kind of a little bit of a red flag that goes up, and that your doctor should want to make sure that it's truly the best option for you. And if it is, to make sure to watch closely. And in that list, there are things like calcium channel blockers. So that's a type of blood pressure medication that in some studies seem to be linked to risk of increased dissection. Moreover, we know that other blood pressure medications like the ARB and the beta blockers help protect you. Stimulant for ADHD, well, in the long run, they raise your blood pressure. There's a class of antibiotics where there's some data that suggests that there's an increased risk of aortic dissection. Again, if you really, really need those antibiotics, you may really, really need them, but sometimes there's good other alternatives. So just making sure that your doctor considered those alternatives and that it's really what you need. In terms of beta blockers, cardiologist talks about non-selective versus selective. Not every beta blocker is equal, so they'll pick with you. We talked about triptan, the type of migraine medications. There's better meds. And decongestant with ephedrine for allergy and congestion. So the ephedrine is something, again, that raises your blood pressure. There are things that, like antihistamine, that can be used. And if you have a cold, what I tell my patient is to ask the pharmacist for something that people who already have hypertension can take, because we don't want to give you something that raises your blood pressure. We want to give you something that won't. And epinephrine, so that's the EpiPen. Well, that raises your blood pressure majorly. But if you're going to die of an anaphylactic reaction, then we will use your EpiPen. But if it's not absolutely necessary, we'd rather use something else. So LDS, as Gretchen stated initially, the journey started about 20 years ago, and we've learned so much in the past 20 years. Thanks mainly to people like you, who are the people who are teaching us. So thank you so much for being part of this community, for sharing so generously, because there is lots more to learn. And hopefully we'll continue to learn and work together, so that next time we give you a talk like this in another 15, 20 years, or that the next generation does, that they can better inform you. Early identification and surveillance is key. Having an aneurysm, yes, is dangerous, but it's even more dangerous to not know that you have one. So there are things that we can do to help and to keep you much safer. And that care, there's not a one size fits all. It's individualized. There's lots of factors that go in. And initially, people talked a lot about vascular care and cardiovascular care. And now there's been great progresses. People are living longer, which also means that people are getting older. And we know that with getting older comes other problems that are probably compounded in things like Loeys-Dietz syndrome. And we're trying to learn more about that to see how we can best help going forward. But this is definitely something that is for you, about you, and where you have a huge voice, because without you, it doesn't matter if it's not for you. So Gretchen, do you want to do the last slide?
So again, our goal is really to empower you, to have a tool to give to your physicians to empower you. So what does that mean? That means that most importantly, we want you to maintain regular imaging. Although vasculature is not the full story, it is an important part of the story. So getting those echoes and those MRAs and CTAs are important. You know, it's increasingly important to know your genetic results, to know at least what gene you have, But I will say it's really important if you're going to different specialists to like know your gene change or at least have that PDF in your back pocket because it is helpful in us making decisions about what we can learn from other people with your same variant. As you can see from that circle graph in the very beginning, some people have a huge multidisciplinary team. Other people, their team might be a little bit smaller, but having that group of people who are following you and communicating and thinking about you is very important. Again, understand emergency symptoms, collapsed lung pain, vascular issues, abrupt pain that is very severe, eye issues, kind of knowing what should prompt you to go to the emergency room that is out of normal. Again, prioritize mental and physical health. I think what Julie and many other speakers at this conference are talking about is that we know that as people are living and living longer, they want to have good bodies to be able to live that long life in. And that includes really good routine cardiovascular exercise. And again, stay connected so you get the newest information, the newest research, and get that peer support. So again, thank you, thank you, thank you. I don't know if we have time for questions, but I saw some of the things. We are happy to provide slides to you, Stacy, and any questions that didn't get addressed will go right to the help desk. So thank you so much.
Thank you so much. This was so comprehensive and so helpful. Lots of great comments and applause coming your way from this group here. And there were a handful of questions asked, but we really are at the end of our time. So I want to encourage you to ask your question to the Marfan Foundation's Help and Resource Center. You can reach them at marfan.org/ask. And a member of our team will be in touch. And thank you again to our speakers and to you all for joining us. Take care and enjoy the rest of conference.